Good afternoon, everyone, and welcome. My name is Amanda Coventry-Barrage, and I'm DWDC's Program Coordinator. Today, I'm joined by my colleagues, Kelsey Goforth, our Director of Programs, and Melissa Muller, Program Specialist. Today, I'm speaking to you from the traditional territory of many nations, including the Wendat, Haudenosaunee, Anishinaabe, and the Mississaugas of the Credit in Toronto and covered by Treaty 13. I acknowledge the legacy of colonialism and the impact it has had on all areas of life for Indigenous peoples, including healthcare. As part of DWDC's adherence to the values of inclusion and people-centeredness, we're committed to working towards recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, First Nations, and Indigenous peoples related to end-of-life care and medical assistance in dying. We will continue to work to listen to and to amplify the voices of Indigenous communities in the discussion of end-of-life choice. Okay, I am thrilled to welcome you today to the second session of Dying with Dignity Canada's Learning Centre. Through this series, we aim to provide comprehensive information on several topics related to death and dying. By attending the 5 sessions over the next month, you should gain a thorough understanding of the issues that matter to you. If you haven't done so already, all sessions and their registration links can be found on our website. We will also be putting the link for the next session on Palliative Care 101. Okay, and before I welcome today's presenters, I'd like to go over a few housekeeping items. Everyone on the call is muted today. There will be, however, opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your questions as concise and clear as possible. While we are also going to try to get to as many viewer questions as possible, unfortunately, we may not get to everyone. If you have outstanding questions following the webinar or questions that are quite personal in nature, please contact us at support@dyingwithdignity.ca and we will follow up with you individually. We will be sending a post-webinar survey that will pop up on your screen after the webinar. It will give you the opportunity to share your feedback. The session will also be recorded, and so you'll be able to watch it again later, so there's no need for you to take notes. Okay. And now to welcome our speakers for today. Caitlin Buchel is a speech language pathologist as well as the owner and managing clinician of Buchel Speech and Language Group, a private speech language pathology practice in Manitoba. She has been a consulting speech language pathologist for the Provincial Medical Assistance in Dying team shortly after its formation in April 2016. Caitlin has been involved in more than 70 MAID cases, facilitating communication between patients and the interdisciplinary MAID team from eligibility assessments all the way through to MAID provision. Caitlin has created a number of communication tools to support MAID assessment and has presented at several venues regarding the role of SLPs in MAID. She has also contributed to the development of CAMAP guidelines on assessment on capacity for MAID. All right, and so that's one of our presenters, Caitlin, and now we have Dr. Lillian Thorpe. Dr. Lillian Thorpe is a MAID assessor and provider. She is a geriatric psychiatrist with dual academic appointments as a professor of psychiatry and community health, as well as epidemiology at the University of Saskatchewan. Dr. Thorpe also spends much of her clinical time performing assessments of capacity with complex patients, but also assesses many patients requesting MAID. She was a member of the Saskatoon Health Region Committee, which developed the MAID policy, and has now been involved with over 400 assessments and or clinical MAID provisions throughout the province. Dr. Thorpe has provided MAID-related teaching sessions at multiple University of Saskatchewan health authority and conference settings. She has been actively involved in the MAID-related research and publication. All right, and now with our 2 presenters, I'm now going to pass it over to Melissa, who is going to conduct the interview portion. Melissa, it's all yours.
Thank you, Amanda, for those wonderful introductions, and thank you to our 2 presenters joining us this afternoon. So this session is all about capacity as it relates to MAID eligibility and assessments. And to just get us started off the bat, Lillian, I was wondering if you could explain what the current rules are around MAID and capacity.
So I'm just going to make sure my sound is coming through. Okay, good. Sounding right. Okay, so the current rules, of course, right now, people applying for medical assistance in dying have to have capacity to make own decisions. And there is as yet no advanced care directive for MAID, although some of us, and I was just presenting at the Commons Committee last night on how we might do this, because there are plans to do this. Right now there isn't. The only kind of other situation where a person might not need capacity currently in MAID is that people have been approved for MAID and they're reasonably in a fairly short period of time going to have MAID, right? So otherwise one has to have full capacity to make the initial assessment for MAID, have the assessments done to be approved by two people who are going to decide if you're eligible. So one has to have, it's necessary to have capacity. It's also to have enough information to eventually then provide informed consent.
Oh, sorry.
I just thought you were starting to speak and you were muted. So.
Oh, okay. So thank you for giving us a brief rundown of MAID and capacity. In terms of capacity, could you just elaborate more on what is capacity and how it would be different from informed consent?
Yeah, so capacity for the most part is the ability to be able to understand material, be able to communicate a choice, which is where we're going to be having some discussions about people who don't do that well verbally. So you have to be able to communicate fairly consistently a choice, be able to understand the choice. You have to have enough mental abilities to do so, and to understand in more detail, to appreciate the applications, the ramifications of that choice to yourself and probably important to others around you. So some of that appreciation is the most complex, and that involves being able to plan and organize and figure things out in a consistent way in regard to your own situation. So that's capacity. So a person can have capacity, but not have enough information to give informed consent. So one has a certain amount of capacity, and then one has to be able to understand and be given enough information to make an informed consent to whatever it is that a person is thinking about doing, right? So, and of course, just when we talk about capacity, that capacity and our mental functions in general are not always completely stable. They might fluctuate a bit. If you have a dementia, they might get a little bit more impaired towards evening when you're tired, or if you've got some illness, and your capacity might be good to understand some things, but not others. So capacity is very task and context specific. And often, unfortunately, it's gray, not black or white. And some of us end up doing really complex assessments where we're not really so sure whether somebody is fully able to understand the issues.
Okay, perfect. So going into a MAID assessment, what is the requirement regarding assessment of capacity within a MAID assessment?
So for the most part, the assumption in healthcare is that a person is capable unless proven incapable. But for important decisions such as MAID, one has to be attuned to any red flags that might suggest that a person may not be. So although that's our assumption, we are we have an onus to really make sure that a person really does understand and have enough capacity to understand a specific decision. So yes, we have an assumption that the person is probably capable, but we also do a little bit more, and we have to document a little bit more about how we decided that a person does have capacity. So we do have to document, and if there are any questions, we have to do a little bit more detailed exploration of this person's understanding.
Okay, perfect. I'm not sure if you mentioned this before, but would you be able to elaborate on what the waiver of a final consent is when it comes to medical assistance in dying?
Mm-hmm. So the latest change in the law happened in March 2021, at which time the government decided to allow people to designate someone to get MAID going, even if that person has lost capacity. So what was happening before is that people they were approved, and sometimes they would be very, very sick, and they might have, say, a big stroke or something, and the day before they were scheduled to have MAID might then not have been capable, because people had to, right before, again, agree that this is what they wanted, and ideally signed, but it could be verbal, but still be capable. And so what happened is that a number of people would then lose the opportunity to die in a way that they wished because they lost capacity. And other people chose to die quicker than they would have wanted to because they were afraid of losing capacity. So the government brought in these waivers of final consent. And in some places like Saskatchewan, we call this an advanced consent arrangement, in that when somebody is in the process of really deciding they are going to have MAID, and it's within a reasonably short period of time, they could designate someone, they sign ahead of time to say that there is somebody that could get the process started, even if they've lost capacity. And I've used this twice now, twice when somebody was completely comatose at the end with really severe illness. So these waivers are signed, and each province has made their own paperwork, how they want these waivers to look, but they would all include some of the basic information, that they would agree to have somebody designated to, say, call the MAID team or start the process if certain situations arose, and you can designate when you want that instituted. So it's a bit complicated for people to understand, because it sounds a bit like an advanced consent, sort of an advanced consent or request, and it is a bit different from a situation in which we want to have some sort of health intervention a long way off for something that hasn't really happened yet. So it's not that, it's when we've made a fairly strong commitment that we want to have MAID and then lose capacity.
Yeah, it's that distinction between an advanced directive, which many people have set up, even when they're quite young, for what might happen when they get very ill. I don't want any heroic measures, that type of thing. This is different. You have to have picked a date in Manitoba. And I don't know if that's the same in Saskatchewan, Dr. Thorpe, but in Manitoba, you have to have picked a date. So if you're not ready to pick a date, you can't sign a waiver. And so it's not the case where you could say, I'll just pick a date 3 years from now, just in case. But it is very complex from a linguistic perspective and conceptual perspective, because there's a lot of if this, then this, but if this, not this, and if this, then definitely this. But assuming all that, you still might not get MAID. It's quite complex, and I've been involved where there's cases where I haven't been involved in the earlier process, and then the eligibility, and then when the individual wants to sign a waiver, I have been asked to be involved to provide support to help people understand, because it is so complicated.
It is very complicated. You are supposed to pick a date, that's the law, but what people do to get around that, of course, they put a date down within which they probably want. And in Saskatchewan, the MAID program has decided 90 days, not longer than 90 days. So you have to give a date. And if any time before that date something happens, you can go ahead. But then what people do is set that date, it's an arbitrary date to some extent, and then renew it once. And Saskatchewan decided they'll let you renew it once without a full assessment. After that, you need a full assessment. So it really is a bit complicated, and that date is a bit of a fudge sometimes, because people don't always know exactly what date, but they have to put a date down.
Agreed. It is a complicated process. And I think too, from province to province, there are differences. I think, in provinces like Manitoba and Saskatchewan, where we're a bit more centralized, there perhaps is maybe a bit more ability to kind of, plan as a group. But even, in some of the provinces where there's, a hospital group in Hamilton, and then also a community group, right? There's all these different groups. I think there is I even see some variation, because I work with all the different providers in Manitoba, a slight variation in how willing they are to sort of how far they're willing to go ahead, how flexible they are willing to be on that date. And again, those concepts of let's pick a date, But if you get sick before that date, if you lose capacity before that date, you could still have it. But if you get to that date and you don't want to have it, then you can sign a new waiver, but only if you still have capacity on that date. Like there's just a lot that goes into it. And like Dr. Thorpe said, it's different in every province, but I would say the conditional statements, if then, and the temporal sort of overlap, that's actually quite complex. Even if your language is perfectly intact from a cognitive perspective, it's a lot. It's a lot of information, especially for someone who's unwell.
Exactly. It's very, very difficult. It's one thing explaining MAID itself. It often is very straightforward, dying or not dying, but the waiver is so complicated. Often people really don't get it. And we're doing them a little bit less now than we were, because we don't really want to get into every 90 days renewing the waiver. So,
Yeah.
it is complicated.
Because it also starts to take up a lot of clinical time of physicians like yourself, right? Because then you have to be present for a new waiver. And so if people are doing those sort of, like you said, every 90 days, whereas you might be able to do a new assessment or a provision for someone who's sort of wanting something urgently. So I think it is like many of the processes with MAID, it's evolving as a practice. And I would say in Manitoba, it's similar, Dr. Thorpe, and that it's evolving towards fewer waivers and being a bit more conservative with them. Like you said, sort of, there's not a firm date in Manitoba, but with this idea that you want to be picking something soon, and then we'll talk about the waiver. But
the other problem with the waiver is what's happening here is that family members sometimes feel really distressed at being the one to start the process. So I had a man with multi-system atrophy. He was hardly able to do any communication, but he was able to still communicate enough to be capable. And we're pretty good here about being flexible about the communication. We work hard with whoever we've got to work with us. And so he was capable, but wanted to live for another few weeks because he had things to do still in terms of his end of life things. And so I had him when his two daughters together, and I explained the waiver, and I said, whose name should go on this? And they both started sobbing. And they said, we couldn't possibly be the ones to call. We would be killing our father. And then the father totally got it. And he said, fine, we'll go ahead 2 days from now. So then that was on Thursday. That was on Tuesday. He went ahead on Thursday. He wanted to live for a little longer, but he was so worried about his daughters. They were so upset. So it is hard to be the one to start that process, even although it was that patient who signed the consent. It's still that family member who makes that call.
And that's sort of always, I mean, so here there in the Manitoba waivers, there isn't someone specific designated to contact, interestingly. So it's really an agreement between the physician and the patient, or the physicians and the patient. And then it could be a care provider. There's no specific designate. So that does help in that it's not sort of specifically on one person's shoulders. But at the end of the day, like you said, Dr. Thorpe, it's still making that call, which is often very hard for family members, even when the patient has capacity, but when they've lost capacity, it adds to that level of sort of burden on the family. And I think that wasn't necessarily all these things that weren't necessarily predicted when they were creating that law and trying to find ways to deal with this issue.
Leeway the provinces have in setting regulatory framework and rules for something that's a federal law. So as in all of healthcare, there are certain parameters that are federal, and then each province basically carries out healthcare. So healthcare becomes a provincial responsibility within some boundaries of federal legislation. So the provinces actually have a fair bit of leeway in how they institute MAID, although they have to all fulfill some basic rules. So you'll see the paperwork being different. In some provinces, one doesn't actually have to use the formal paperwork. You can use your own paperwork. In Saskatchewan, you have to use the formal paperwork. I think Ontario, you don't. So there is a lot of different stuff that provinces can do, which makes it a bit confusing when people move to different provinces. That really a challenge.
Thank you so much for it. That was a lot of in-depth knowledge of waivers of final consent. It's definitely something that is still quite complex. Would you give any recommendations for any patients or people who are looking at the waiver of final consent and what any recommendations would be when using it or the best approach?
Yeah, I mean, I'm now not really doing it unless unless a person is clearly wanting to go ahead with MAID within the next few months. And if they're really not, I'm not doing it. Now, I mean, there are situations where I might be really worried about a person losing capacity and they don't quite understand that. So I might suggest to them, and I've just had a case like that where, and a person is actually now really declining quickly, where I might say, let's do this. And so for the most part, there isn't a hard and fast rule. It's really very case based, and it's up to a little bit each assessor as well. It's how close you are to that person. If I think that person is in my same community, I can get out on the way home to see them, to update something. I may be less worried than if that person is a little bit ways out and I may not be able to. So it's case-based. I don't know what Caitlin thinks of that.
Yeah, I mean, I would agree with Dr. Thorpe that it's certainly case-based. Interestingly, I think it's this combination. Dr. Thorpe hit on something. One, sometimes we're very worried that someone will lose capacity. So a glioblastoma is a good example. I see a lot of those patients, and they, can have capacity and then they can lose it. And whether that's due to swelling, whether that's due to tumor growth, whether that's due to a bleed, and so often I those are the ones that keep me up at night. I worry about them losing capacity. Interestingly, I was with a gentleman yesterday, and he had a waiver signed, and the time had come, and he was not ready. Which is always that we support people that that's great if you're still having quality in your life. And his family was very concerned about him losing capacity and wanting him to sign another waiver. And so he had a bit of aphasia, so language difficulty. And so I was talking to him about that, using pictures and calendars. And interestingly, when we really got down to it with him, he actually really, and so we talked about, well, what if you had to be in a personal care home? What if you had to have a brief? What if you were in a coma? You were very, very sick. You were in a coma and you were there for, 3 weeks. And he said, well, that's okay. As long as I don't feel anything, I'm fine. Which is, I think we often assume, and I would say my experience is more that people say, I don't want that. And that's where we talk about that waiver. But I think, so it's this combination of, if you don't sign that waiver, what is death going to look like if you do lose capacity, right? And with glioblastomas, often people can linger. And so I think there's often, but again, I was surprised yesterday by this gentleman. I think his family was too, to hear him say, like, no, I'm feeling good, and if and when I'm ready, I'll call you. And if I lose capacity, well, then as long as I don't, make me feel good, and I don't care, So whereas other people have they want, as Dr. Thorpe said, they want to know that they won't linger, that they have control over the manner and timing of their death. So yeah, that's I think at the end of the day, it's very individual, and certainly that rural urban proximity to services, if it's going to take us 6 hours to fly up or drive to someone, it makes a huge difference versus, as Dr. Thorpe said, if she can drive on her way home from the hospital, right? So
the dementia and Alzheimer's in dementia, so there was some commentary again on that. That is probably the most difficult one to do a waiver for, because capacity loss is generally very gradual, and a person generally doesn't want to die for a long period of time. So that becomes really where some people want to have an advanced request, which is a different kind of thing, because most of those people, now the exceptions might be somebody with a rapidly advancing dementia. So someone with, say, a Creutzfeldt-Jakob, I'm not sure if any of you know what this is. This is a very rapidly advancing dementia, which I've only seen a few of in my career, but it's a potentially transmissible one with a prion disease. You can get it from eating wild meat, for example, and that is extremely fast. And so those people, yes, absolutely. But a regular Alzheimer's, it would be probably not right now, unless a person is deciding that they want to have MAID fairly soon. So we actually have someone like this week who is very clear she doesn't want to live like this, and she has lost a fair bit of short-term memory already, but she is ready to go ahead. And so, but we didn't do a waiver because It's a very slow progression. There's nothing to indicate she's likely to lose capacity quickly, because that's what we need to do.
Okay.
So yeah, so personal directives, you see, these personal directives, these don't actually let us go ahead to do MAID, but they're extremely helpful if we see them. Because if I was to have questions about what a person would have wanted, say somebody has a little bit of impairment already, I generally look at everything about their past lives to get a sense of, is this consistent with what they would have wanted? The person had made a personal directive and attached all these instructions. I find that extremely helpful, so that because capacity assessment is task and context specific. So if I have a lot of context that shows that this person clearly always wanted this, I will be pretty flexible with approving this person. So it is a pretty helpful thing to have.
Yeah.
We should all be doing these.
I agree, and talk. We've talked to people, again with, let's say, a primary progressive aphasia, so a type of dementia where language goes first, and they say, well, what can I do? I want to do an advanced directive, and something we talk about is, one, while it's not legally binding, it's exceptionally helpful in terms of consistency. The other thing, if you have a family doctor, talk to your family doctor, because again, someone like Dr. Thorpe is going to be requesting those records from your family doctor. And so if Dr. Thorpe sees that this is something you've discussed with your family physician, and your family physician goes, oh yes, we talked about this and I know it's consistent, with her wishes, it doesn't mean that you don't have to have capacity to consent to MAID, but it does, if there's any kind of, are we sure? Or it really is supportive to say, okay, this is consistent with who they are, what they've wanted, all of the wishes they've described. It's very reassuring if we have any kind of concerns, because like Dr. Thorpe said, it would be nice if it was black and white, but for the most part, it's all gray.
Yeah, so Louise Schwartz made a really good point that we should read out the questions because they can't all see them. So for those ones who didn't see the question I was answering in July 2019, this was, I can't remember who this was, the person he's talking about had a lawyer do a personal directive, which included a chart of instructions saying that if she developed severe dementia, etc., and specified how bad it would be, she would want a physician-assisted death. But that was before Bill C7 was passed, and so he noted that if there was a MAID assessment, that she would not have capacity to agree to this. Now, so it just depends. So they could be people with a lot of impairment I've approved because they may not remember me from day to day, but every time I've seen them, they've told me that they want MAID. They don't remember my name, but they tell me exactly the same thing each time. So that information would make me really feel strong, more confident. So technically speaking, if she's so advanced that she can't communicate at all, no, then she couldn't have it. And so Joan McLeod asked what the difference is between advanced directive, personal directive, and advanced consent. Are these interchangeable, or is the terminology province specific? There is some province specific stuff here about these various issues. For the most part, advanced consent and advanced directive, these are currently available to stopping treatments when a person reaches a certain stage. But yes, there are some difference in terminology again throughout the province. So you have to be pretty careful how you read it and where you are.
Great. Thank you so much. And thank you for taking the time to answer the questions that we have. If we have any more at the end, we'll be able to speak more about those. I just wanted to get back to switching gears a little bit to how we approach capacity. So Caitlin, in your role as a speech language pathologist and working for patients who are seeking MAID, so what are some practical strategies that can be used to optimize understanding and development of informed consent?
Yeah, so, and I mean, Dr. Thorpe is a specific kind of physician. She's got this geriatrician background that means that she has a really good knowledge base as well. And some of these just sort of basic strategies that we want to use, that we don't realize the impact that they can have on someone's ability to understand information, because our ability to understand information, which is really important when you're when we're determining capacity for MAID is based on so many things. So, even having a window open with people walking by is a lot of visual noise. Needing glasses and not having your glasses on or having them covered in lotion, which is great for the skin, but really not good for our thinking skills. And we've got some really great evidence, the impact just being able to see, if that's something that you're used to, can make on your comprehension. Same thing with hearing. And this is, more so with our 60 plus population, but, I was asked to come out because they were concerned that someone had lost capacity. They weren't sure. They were trying to sign a waiver. They weren't sure what was going on. And she was, I can't assess her in that context, and I said, do you have any difficulty hearing? No. And I thought, so I put a pocket talker on. And for folks that aren't familiar, I'm not associated with this company at all. There are likely other brands that do this, but pocket talker is one that I use. No endorsement implied, but simply it's a headphone. So there are some that go in the ear, but honestly, for most people, they prefer the headphones, and you can just put some little covers on them to make them sanitary. And they go on the patient's ears, and then I speak into a microphone. And while, any audiologist who's on here would have my head if I suggested it's the same as hearing aids, for people who, where that's not an option, or their hearing aids don't work, they don't have batteries, they can't get them in their ears, a pocket talker is amazing. And once we got this amplifier on this woman, she didn't even realize the hearing loss. And basically, they didn't really need too much of me. So if you have a relative, or if you're someone that struggles with hearing loss, you can get these for $100, $200 on, well, anywhere. But even, if you're limited to online shopping, certainly even Amazon. I think Canadian Hearing Society has them as well. So if you're wanting to support them. So that's something that's really important. So thinking about these basic sensory inputs is really important. And then thinking about the rate at which we speak. And I'm speaking fast today because I like to tell you all the things that I know. But slowing our rate. So that doesn't mean talking like this. That actually worsens people's comprehension. But slowing our rate so that people have time to process what we're saying is really helpful. The other thing that Dr. Thorpe has spoken on, and I think is really a really great point, is that often, because women's voices are higher pitched, they tend to be in terms of range, and age-related hearing loss tends to affect highest pitches first. Sometimes individuals struggle more with higher pitched voices. And so you may be better to sort of, not speak like this, but to even just bring your voice down here to help people hear. So that's all sensory stuff. Then we have things where we're looking at the complexity of questions. So even in a MAID assessment, if I say, oh, Melissa, it's so, thank you for having me here today. I hear you've been thinking about having an assisted death. Can you tell me, how are you suffering physically, psychologically, spiritually, emotionally? Right? And yeah, it's a lot. And now, and you're well. Right? So now we've also got to be imagining someone who's unwell, typically, and also it's a very emotional conversation. So thinking about, we're never speaking down to patients, but keeping, one question per, I sort of say utterance, but, I might say, can you tell me about your suffering? Or how are you suffering? Or more specifically, do you have any physical suffering? And then if they say, oh yeah, then we can talk about telling me about that. The other thing that we tend to do is, so Melissa, you don't have any physical suffering, do you?
No.
I don't know. Do I? Yes? No? What's the right answer to that question if I've got a real pain in my back? Hard to say. Those tag questions where you say, don't you? Do you? Get rid of those. They're things that we don't even realize that we do. Again, physicians like Dr. Thorpe, where this is what she does for her, she's always working with these complex cases. She has a bit more of a sense of that, but it can be difficult for, assessors and providers that don't necessarily have these complex conversations with really unwell or compromised patients all the time. So those are the other thing that I always say is, We want to make sure we don't always ask yes questions. So in the health field, we are a helping profession. And we have a tendency to ask questions because we think someone might want something. So are you hungry? Are you cold? Are you thirsty? Can I help you? Right? If I answered yes to all those questions, okay, great. But I really actually, as the healthcare provider, have no idea if you've understood them. Because if someone, if you're not well, or if you are, and someone's leaning over and smiling and being kind to you, putting a thumbs up, the tendency is, well, like, yes, I want all of the things, right? Whether I've understood it or not. And so, I know that, the MAID physicians are very, assessors, I should say. In Manitoba, I should clarify, I use the word physicians because in Manitoba, due to a complicated but sort of odd law, nurse practitioners aren't allowed to provide MAID. But again, it's a technicality. So I use the word physicians because it's largely physicians here. But just to be clear, in many other provinces, nurse practitioners are involved. But that's something to really think about, is making sure, and we always do this, especially the day of provision, to say, if we just come in and say, like, do you want help to die today? Right? What is, right? What is anyone with any kind of sense in their head going to do? Like, yeah, right? So making sure that we ask things like, have you changed your mind? Do you want to wait to have help to die today? It doesn't, on that day of provision, we don't tend to get very involved unless there's some reason to get involved with questions, but making sure, okay, I've got a yes, I've got a no, they kind of make sense, they're consistent, they said yes, they want to go ahead, no, they don't want to wait. Those are sort of tips that we would give other healthcare providers, so whether physicians or nurse practitioners, when they're talking to individuals about MAID, whether or not they have language issues or speech issues, which is sort of where I spend more of my time when people have those issues. And I can certainly speak specifically to that, but I'm not sure. I have some examples, but I'm not sure if you want to do that now or wait. Or
we might, if we have time at the end, we might be able to do it then, just because we're halfway through and we still have a bit of questions that we want to have you both answer. So you've talked about, your patients who are able to communicate verbally. What about when someone cannot communicate verbally, and how do you determine capacity then? And if so, or if there's any tools that you would use in those situations as well?
Yeah, so it really, the tools that we use depend on the nature of the person's difficulty. So if it's simply a speech difficulty, and a good example that I think lots of people know of is Stephen Hawking, right? There's a gentleman who cognitively, for the vast majority of his life was very intact. And the problem was with the muscles, right? The muscles basically just didn't work. And so he could use something like eye gaze. So using his eyes to look, whether it be at a low-tech board, we call it an E-Tran board, or a high-tech computer screen. So we have computers that can watch your eyes and you can select letters and words and spell out your entire message. So when it's specifically speech, I tend to have more options because it's really just a motor problem. And so it's just figuring out at its very basic, if we're limited in terms of the patient's energy and tools, at its very basic, what's a way to say yes or no non-verbally? And what I always say to people is, you don't want to say blink once for yes and no times for no. No response is not we don't want to count on that as a response. So if someone only has one response, I had a patient like that, where really she could only just kind of get one little blink, but she couldn't do two blinks, like that was too much. Then what we do is we kind of cycle through options. So I might say, I'm going to ask you a question. The answer is going to be yes, no, or something else, because sometimes the answer isn't yes or no. So we don't want to force people into that. I tell them the options and then I say, okay, and I want you to blink when we get to the choice that you want. And remember, the options are going to be yes, no, something else. And then I'll say, here's the question, yes, no, something else. And I'll wait for them to use that motor movement. So it's, as I say, we have a fair bit of flexibility when the issue is speech or those motor movements. We can use a toe. We can use, eye blink. There's lots of options. Where it's more challenging, but again, we have tools, is when someone has something called aphasia or difficulty with language. So difficulty connecting a word with So someone with aphasia knows what this is. They know what to do with it. And they go to say it and they say, well, it's a phone. Nope. It's a pencil, right? They can't quite get that word. The challenge is often they have difficulty also matching when they're understanding those words. Same thing with reading and writing. And so and I can, if that's okay, I can do a quick screen share to show a couple of pictures that we might use.
Sure.
So I've developed basically with volunteers and some images, and I'm just going to try and share my screen just to give you a sense of what some of those might look like. So you can see here, hopefully, whoops, let me go back.
You can see it.
So those are some photographs that I've taken with our MAID team and some volunteers, some family members, my family, not patients, just to be clear there. And so when we are trying to discuss certain concepts, someone who is trained in doing some supported conversation, and that doesn't have to be a speech pathologist, but it's nice if they've had some practice, can use these pictures or photographs to help someone discuss a concept. So, here well, it's on my right, I'm not sure how it's mirroring, but on my right, we have this woman who's sort of, pushing away, going, no, that's not what I want, right? Whereas on the other side, we have a gentleman who's, receiving help to die. Another type of support that we use might be something like this, and please just ignore the image on the bottom looks like it's painful, and it's not at the end, so forgive that image. Where I'm trying to use images from an existing source called the Aphasia Institute, and they don't have a good one, so I have an artist who's helping me with that. But you can see that we can also use line drawings. It's okay to change your mind. Sometimes individuals, though they have difficulty with understanding what they hear, they can read. For example, single words, usually not whole sentences, but single words. So there's lots of different options. Some patients can understand really concrete information. So things like, I reassure patients, listen, you don't have to be able to talk at the end. You can, point to a picture. Others can understand sort of more abstract concepts that are harder to represent visually, like, is anyone pressuring you? How do you show that? How do you draw a picture of that? And so here's some examples that we might use. The challenge there is for some people, that's just really it's a very abstract concept, and so it's hard to understand. So those are some examples of some of the things we might use. I'll stop sharing there, but just to give you a sense or a flavor of some of the things that we might use to support someone in understanding the information, even if their language isn't strong, and also communicating their message out.
What about if someone isn't fluent in English or French? Are there any other tools that can be used when communicating with a patient?
I mean, and Lillian, you can speak to this we would typically use a medical interpreter, just like we would. Yeah, absolutely. I mean, just like we would with any other medical discussion about sort of medical procedures and things like that, we would not use a family member. We would use when at all possible. In my experiences, especially in these legal contexts, we don't want to use the family member or even a community member. We use interpreters, and actually, if anything, COVID has advantaged us somewhat in that even we're now able to access a lot of rare dialects via phone and web that we weren't before, because there's been some investment in that. So
perfect. Thank you so much. So I have a question for you, Dr. Thorpe. Are there specific considerations when it comes to determining capacity for MAID?
Specific considerations for MAID? Well, we would have to, it depends on the condition that person has. So capacity, how stringent we are in our capacity assessment often depends on how much risk we have in the whole decision about MAID. And I'll tell you what I mean by that. That when somebody is dying very quickly of glioblastoma, for example, I don't expect that they need a huge high degree of abilities to be able to think through everything, because they're going to die anyway. If somebody, like we've had lots of people with multiple sclerosis who might live for another 4 to 6 years or 8 years still, I expect them to have a higher understanding of what's going on because they're cutting off more years. So the degree of risk is going to determine how careful we're going to be. In general, though, somebody has to understand the concept of MAID, what's wrong with them, how long they're likely to live without with what's happening with them right now, what's their life expectancy, what sort of treatments are available, what are the side effects of those treatments, are they acceptable to that person? So MAID involves a discussion specifically about their context, their health context, what that MAID would do versus what the other choices would be that they would have other than MAID. Can they talk through, say, palliative sedation and MAID, and maybe they're still getting chemotherapy and so on. So it's very sort of centered on understanding that context.
Perfect. Thank you so much. Caitlin, another question, and you kind of talked about this a little bit with aphasia, but how might you deal with an anticipated progressive loss or language or speech, such as ALS or primary progressive aphasia?
Yeah, so I think there's no question with those assessments, it's really nice to be able to do them while those sort of initial conversations and assessments, Dr. Thorpe talked about sort of being approved. Often people will be approved sort of based on their existential suffering, sort of knowing what's going to happen to them and it being so devastating that they are once they know they can have an assisted death, actually, often just knowing that relieves their suffering. And so I find with these progressive type of illnesses, it is great, honestly, when we can have those conversations a little bit earlier, because like Dr. Thorpe said, it does allow you to get into some of those more detailed, specific, the difference between palliative sedation and having help to die, having MAID. Some of those distinctions that are much harder to make and much harder to make sure that someone understands when you're limited in terms of your speech and your language. And so it is always nice when we can have those conversations. And then I typically plan. So I think, okay, what's this person's current communication system? What can they currently do? What do we anticipate might change? And it's, it's not, we have a sense of what will come. And if it doesn't, fine. But I always want a backup plan. So if this person is currently, for example, using a high-tech system, let's say they have ALS and they're using a head mouse, so a little dot here where they can select things on the screen and it'll speak their message. That's great, but unfortunately with ALS, if it progresses far enough, you typically lose head control if it's a bulbar progression. So if that's the case, what's our plan, right? Do we have something low tech if they're in bed and they need to communicate? So I usually like to do a little bit of planning with that person to say, okay, can we use just a simple, yes, no, left, right, what's sort of preserved, what's not going to be preserved. I also like to try and connect, so especially with aphasia, trying to connect concepts to images. So for example, with primary progressive aphasia, if I use that image of the gentleman receiving medication, it's actually milk, just to be clear, through that fake IV. But if I'm using that image to represent MAID, because again, even thinking about that, what is a picture of medical assistance in dying, and how is it different than perhaps receiving palliative sedation? How does it look different to someone who doesn't do those things, to even to a physician, right? And so in those instances, when we can speak with someone, for example, with PPA, primary progressive aphasia, and help them connect that image to the concept of MAID, then when we come back later and perhaps their language has deteriorated further, there's more of a chance that that image still represents that concept of MAID to them. And so we can have a better discussion than if we've never introduced those visuals at all. So that tends to be how I look at planning for those things. Again, things happen that we don't anticipate, but I do try and have some backup plans in place, as things progress.
That's such a good discussion to do this early. And I had a very young woman with ALS, and she wanted to live as long as she absolutely could. She had three fairly young kids still. Well, I say young, like late teens and early 20s. And she wanted to live as long as possible. She had her discussion relatively early when she could still communicate a little bit, which is what I strongly suggest in people with ALS. You start early, especially with a kind of ALS we call bulbar, which affects language early. And that way, if there are a few longitudinal assessments of that person, we talked about how she would tell us when she wanted to go ahead. And by the time she went ahead. All she could do is 2 different kinds of grimaces. She couldn't even turn her head anymore.
Yeah.
But he was able to very clearly grimace in a way that was different to yes and no and was consistent. And we felt that this was a competent decision based on having had a longitudinal connection with her. And we had actually discussed how was she going to tell us? How would she like to communicate with us? The other thing we asked her is, if I'm not sure, who should we ask to interpret for us? And so if she says, my husband understands me best, which I thought was the case, then we would then, if we're not sure, we would ask her husband. And so she lived until she couldn't even turn her head. She couldn't turn over in bed. Her husband had to wake up and turn her over, but it's what she wanted. She wanted to live until the last minute. She eventually got an infection, pneumonia. I got a text from her. I always give people my cell when they're approved and when I think they're might decline quickly. Get a text from her late that evening. We're able to do MAID first thing that morning. And you know, all she could do is just that grimace, 2 different kinds of grimaces, and it was absolutely clear. So do it early. We did.
Yes.
We have a good connection with the ILS program, and one of our research projects we did is actually exploring when they talk about end of life stuff. And as a result of that research project, I think they're discussing it much earlier than they used to now. And let me talk to them early. Let me talk to them, document what their wishes are. We know what the subtype, how ALS doesn't always look the same and looks different people, different variants, but we have the information and do that discussion early, file it away, and have our 2 assessors both see them. We file it. It doesn't run out. As long as that person can still convince us they know what it is, they don't need a really high level.
Yeah.
Perfect. Thank you so much. So we're almost at time, but I wanted to talk a little bit, and I know Dr. Thorpe, you had briefly touched on this earlier in terms of dementia and MAID. And so just to, you know, we get a lot of questions from our supporters in terms of if I'm diagnosed or a loved one diagnosed with dementia, do I qualify for MAID? And there's many myths out there. So can a person with dementia qualify for MAID?
Yes. So a person can, currently only in a window. So the window in which you're eligible is when you've lost enough capability in your everyday life that you fulfill that criterion. So you have to have significant, it's an illness that's not going to get better, and you have to have lost significant capability as a result of that illness. But you can't have lost so much capacity that you can no longer consent. So that window, within that window right now, people are eligible. And that window can last quite some time. And with that discussion, you know, one has a bit of a sense on how fast a person's progressing in their cognitive impairment. If you see them a few times in a row, if they're progressing quite fast, that window might be short. If they have a slow progressive typical Alzheimer's disease in somebody might not be very fast, although the proviso is that very bright people with Alzheimer's often have a lot of compensatory strategies. And those compensatory strategies mean they function quite well, even although I scan their brain and their brain shows very advanced damage, but they're still functioning. When they lose compensatory skills, they will then have this very rapid drop in functioning. We call it the cliff drop at our geriatric program. And so that cliff drop is really fast in very bright people. And so you'd want to know the context. And again, having that assessment done early, documenting those assessments with both people, and then making sure we stay in touch. So right now, I have a case happening actually tomorrow. And this is a woman who, very bright. She was very aware of her loss of capacity. She sometimes struggles to find the right word, but she's very consistent. And she is in that window. And she also wants to be the one who decides. So this whole debate we're having in the Commons yesterday, the special committee that's looking at advanced directives, it isn't always what people want, that somebody else eventually will decide when to cut off your life. People have told me that I want to be the one to decide. So I'm not going to wait until I'm lying there not speaking. I want to decide, and I'm going to do it when I can still decide. I don't want anyone else to have to decide either. So yes, you're eligible. online resource on Cliff Drop. This is a term we use, but I'm not sure if you'll find anything if you Google it. But if you look at adaptive skills or compensatory skills in dementia, you may find something. But most of us who deal with dementia are very aware of this.
Okay.
You really also see it, Dr. Thorpe, I was going to say, you really see it often too if someone is moved. So if they're super high functioning and they've got all these compensatory strategies, procedural memory within their own home, and all of a sudden you move them to a different home, all of those routines and procedural based, because procedural memory is memory for routines, and it is so amazingly resilient. And all of a sudden you switch their environment. You can even see it when if you renovate the kitchen. And again, you can kind of see that sudden, and it's like, oh, they're suddenly getting so much sicker. And in fact, no, what is often happening is that all those compensatory skills that they had developed are no longer functional because the routines that they had developed and practiced and had become a part of their routine, they're gone. So yes, definitely that's something we see too as well.
So this, Natalia has this great question. So the fear of losing capacity with a dementia diagnosis, can a person request and get MAID at the first sign of diagnosis of dementia? And the answer is no, because the law says, I'll just have it all up in front of me, says that you have to have a serious and incurable illness, disease, or disability and be in an advanced state of irreversible decline in capability. So in the early stages of dementia, when you're just diagnosed, you don't have that yet. This is why you only have this window at which you're eligible right now for MAID. You have to get bad enough that you're not able to do lots of the things you used to be able to do before, and that's not going to get better. And you can still have enough ability to say what it is that you want. So that's a window. But no, when you're first diagnosed, you're not eligible. Now, if there become advanced directives for MAID, as has been hotly debated right now, then you could possibly fill out that directive and specify exactly what it is that would tell your family members to go ahead when you've lost capacity. Although this is all very complicated, because if a person loses understanding that they have dementia, many of my patients no longer think they have dementia. They're quite happy. They're walking around enjoying themselves. I'm actually not so bad anymore. None of us is going to hold that person down and inject them against their wishes. It is not going to happen. So, or if a person is so aggressive, you can't even get a needle into them or to take the medications, it's not going to happen. So advanced directives are going to be helpful for our comfort, but are not always going to be very usable.
Yeah, complicated.
Very complicated.
Definitely. To go back to the waiver of final consent, can that be used? I'm not sure if we talked about this a little bit earlier, but when it comes to the waiver of final consent and dementia, can the waiver be used?
Well, you see, that's the problem, that the waiver is not usually very usable for dementia, because the capacity declines very, very slowly. And you have to be able to say for a waiver that you had significant risk of loss of capacity, and you're supposed to also do this in the short term. So this is not a long away kind of thing. So usually waivers not very helpful currently the way they are for dementia.
Okay.
The time I've seen it be used and used effectively is if someone is really near the edge of losing capacity. They have dementia, but they want to make it to Christmas, and that's Christmas is 2 months away, and they really want to have one more Christmas if they can, or someone's birthday or someone's wedding anniversary. So again, like Dr. Thorpe said, very, very close at hand. They're close to losing capacity, but haven't lost it yet, and still have the capacity to fill out that waiver, which is no easy feat. Then that is when I've seen it be used effectively with dementia. But again, much I think used much less because again, in practice, it's just much more complicated than one might think.
Okay. Yeah. So, thank you. Oh, sorry. Go ahead.
This question about Gillian Bennett. So Gillian Bennett was a woman who talked about so I've just pulled her up so I get all the details right. So she's a woman who was concerned about she was 83, and she was worried about getting dementia and dying before she got it. And so she chose to end her life after 83 years because she believed she where life was an empty husk. So she had dementia and so on. So that is one of the arguments for an advance directive, that sometimes people feel that they should be able to say this without having to die too early. But there are other people who choose to die early because they wish to make their own decisions. So this is why this is a very complicated thing. So many people are like Gillian Bennett. Once you know you have a deadly disease, you make a decision that you are not going to go much further in that disease. And we're all very different in how much we accept, how far along we're going to go with this. And she had a diagnosis already and some loss of capacity. She probably was capable at that point, as have a number of people who have had dementia that I've had MAID for. And so they may choose that because they may choose not to go in much further into that dementia process. And you may say that sounds sad, but you know, at 83, sometimes people make a choice that they may not want any chemotherapy for their lung cancer either. We make different choices. And then other people who take every single treatment known to man and, you know, and want to live an extra 3 weeks. We're so different, all of us.
And there are those people in the middle who, you know, something that we hear a lot is, I have a picture for this, like I don't want someone else to wipe my butt. That's a bit like sort of, you know, right, like a dignity piece. And it was funny, I was just with this gentleman who that was his line in the sand. Like the doctor's like, what do you think your line in the sand is going to be? He said, well, someone has to wipe my butt. Absolutely not. And I was just seeing him yesterday just to kind of do a serial assessment and check in. And basically what he communicated to me is actually, it's not so bad. You know, like I don't mind that so much actually, you know, and then what was his other thing? He said, oh, you know, and what he did say is right now he's able to communicate with these supports with his family, but when he's not able to do that, he's decided like that will be, so it'll be interesting as that approaches if that's, but sometimes people have these sort of lines in the sand, and then as those approach, whether they've changed cognitively or changed from a personality perspective, or just, you know, we don't necessarily know until we get there. And that's okay too. And sometimes those lines in the sand do shift. So, you know.
That's such a good comment to make, because that's the trouble with advance directives.
Yes.
Because my patients are always telling me very commonly something they wrote in an advance directive 10 years ago, it's no longer what they want, but they haven't reviewed it. And exactly, I don't want something now, but actually you get used to it. So that's the trouble. So then there's this person in a long-term care facility who's walking around, has to get her butt cleaned, but she's actually enjoying singing. She's enjoying visiting with the other residents. Some of them actually mistake another resident for their spouse, and they can be quite happy. And then as a family member looks at this advance directive and says, if I can no longer wipe my butt, they want to die. So are they going to want to tell us that we have to hold down that person and inject them? They might think they have to, but would we? Probably not.
Exactly. And we've certainly seen family members where they said, well, my mom said she would never want this, right? But we look at mom, and mom is okay. Mom is happy. Mom is content. She's not showing any signs of pain. She's showing that she's quite content. But the family member is just so distressed because they feel this sort of moral culpability that they're not, you know, sort of fulfilling their mother's wishes. So it is, again, you know, there are certainly cases, you know, I think we're talking about the complex ones. There's certainly cases that are more straightforward. But most of the ones that, you know, we deal with, Dr. Thorpe and myself probably deal with, are these more complicated ones. And it's just never quite as clear cut as we'd like it to be.
Thank you so much to the both of you. I think that's all we have for today. And we've been able to answer quite a few of the questions in the audience. Thank you for being on that, Dr. Thorpe. And if there's any other questions to the audience that you have, feel free to email support@dyingwithdignity.ca. But I do want to say thank you again, Caitlin and Dr. Thorpe. This was an amazing session. Your expertise and knowledge on this, I learned something new, and I'm sure so many watching today, and this is going to be available on our website in a couple weeks. So this is going to be a great resource. So thank you so much to the both of you. And our next webinar, for those who are watching, will be, the next webinar, sorry, of this learning series will be next week on Tuesday, May 24th, and it will be on palliative care. And the link to the registration will be in the chat for you. But again, thank you so much to the both of you. And I hope that everyone has a wonderful rest of your Tuesday. So,
Thanks,
thank you.
Melissa. Thanks, Dr. Thorpe.